So let's talk about tumors of the pancreas. And tumors of the pancreas are three types. What were the three cell types in the pancreas? And what hormones do they produce? Remember that there was the alpha cells that make glucagon, beta cells that make insulin, and then delta cells that make somatostatin. So we're going to talk about insulinoma, which is then a pancreatic beta cell tumor with oversecretion of insulin. What happens to your blood glucose? You get hypoglycemia. Now, I'm sure you probably experienced symptoms of hypoglycemia before. If you haven't, it's just general stuff. I mean, you're hungry, you might even feel nauseous or vomiting, you might feel a little tachycardic, your heart's beating, you get palpitations, you feel sweaty. And then if it gets really bad, you can get altered mental status. That's when your blood sugar gets really, really low. Because why is that? Why would hypoglycemia cause altered mental status? Because remember that your brain needs glucose for energy. So if you're not getting energy in the brain, you're getting altered mental status. So these are all general symptoms. Don't memorize them, but be familiar with them. And the one thing we want to know is it, let's say you have a patient with very low glucose. Is it due to an insulinoma, or is it because they're using too much exogenous insulin? Either because they're diabetic and they need insulin for treatment, or because some people like to stick insulin into themselves and cause symptoms. And what molecule do you want to measure to be able to differentiate? Remember that the molecule would be C-peptide. Why is that? Because remember that C-peptide and insulin, when made naturally by the body, are secreted in equal volumes. So if you have a tumor that's making too much insulin, it's going to be making too much C-peptide as well, and you're going to have high C-peptide. But if you have exogenous insulin, there's no C-peptide in exogenous insulin, so they're going to have non-elevated C-peptide. So that's how you differentiate. So that's it for insulinoma. Next, we're going to talk about glucagonoma, which is alpha cell tumor with oversecretion of glucagon. And what happens to blood glucose here? When glucagon increases blood sugar, you get hyperglycemia, you get diabetes. What happens remember, is glucagon anabolic or catabolic? Right? It increases blood sugar, and to do so, it's catabolic. It breaks down your muscles, it breaks down your lipids, so you get weight loss, you get GI symptoms, such as diarrhea. So that's diabetes, that's GI symptoms, and weight loss. Finally, and there's the most characteristic thing here, is you get a necrolytic migratory erythema. So what is this? First, you start with painful and itchy plaques and papules, and on the face, let's just draw this: face, groin, and extremities. Okay, hands, legs. Elevated, painful, and itchy plaque, and then these plaques and papules are going to coalesce to form a large lesion with a bronze-colored central indurated area. That's necrolytic migratory erythema. So you get plaques and papules, they coalesce and they form a large lesion, and there's a bronze-colored central indurated area. You get this, and then this stuff you know from glucagon. So you do have to memorize this though. All right, finally, somatostatinoma. Which pancreatic cell makes that again? Remember, it's the delta cell. And what does somatostatin do? Remember, somatostatin we call it somatostopin. It blocks secretion of a bunch of hormones, including a bunch of GI hormones. So stuff like CCK, secretin, it blocks insulin, it blocks glucagon, it blocks gastrin. So you're going to see a triad of symptoms here. You're going to see hypoglycemia, you see gallstones, and you see steatorrhea. Why would you get hypoglycemia? Why would you get hyperglycemia? Because you block insulin, you get hyperglycemia. Why would you get gallstones? Remember that you block CCK. CCK is for stimulation in the gallbladder. So now you have gallbladder stasis, you get gallstones. Why would you get steatorrhea? First of all, what is steatorrhea? Remember, steatorrhea is greasy stools. And why is that? Because you're blocking secretin. Secretin is used to stimulate the exocrine pancreas to release digestive enzymes. So you're not getting digestive enzymes. You're not breaking down all that fat that you ate, and that fat is coming out into the toilet, and it's going to be greasy stools. So that's it for somatostatinoma. Next is another endocrine tumor. This is not an endocrine tumor of the pancreas though, but I'm lumping it in because it's another endocrine tumor. It's a neuroendocrine tumor that commonly develops in the GI tract, especially the small intestines. However, it can also develop outside of the GI tract, for example, the lungs. And this tumor secretes high levels of serotonin, okay? Now, the thing to add is tumors in the GI tract don't cause symptoms. Why is that? Well, let's say you have a tumor in the small intestine. It's releasing serotonin, goes into the portal veins. Remember that these blood vessels go into the portal veins. Portal vein goes into the liver, and then your liver is going to break down this serotonin. It's going to metabolize it before it can reach systemic circulation, so you don't get symptoms. However, if the tumor is located outside of the GI tract, for example, the lungs, or if the tumor metastasizes to the liver, then the tumor products can be secreted directly into the systemic circulation, and you get symptoms. Now, what symptoms do you get? First of all, if you do get symptoms, then we call this the picture of symptoms, the carcinoid syndrome. What you get is you get episodic flushing, diarrhea, wheezing. Super characteristic. See, episodic flushing, diarrhea, wheezing, it's a carcinoid tumor, carcinoid syndrome. Finally, you can also get right-sided valvular heart disease. Why is it right-sided and not left-sided? Well, first of all, what's anatomy? Remember, we're dumping the stuff into the veins. Where's the veins going to go? Into the inferior vena cava, going to go to the right side of the heart. So you're going to get damage from the right side of the heart from all that serotonin. And then it goes from the right heart to the lungs, and the lungs happens to act like the liver, and it's going to break down the serotonin, so the left heart does not get affected. Finally, you can get pellagra. What is pellagra? Remember, pellagra is a niacin deficiency. What is the symptoms of it? Remember, what's the mnemonic that we have? The 3 Ds. Diarrhea, dermatitis, dementia. We get pellagra because you need tryptophan to make serotonin and niacin. Now, if you're making a bunch of serotonin from this tumor, using up all this tryptophan for that, now you get less niacin and you get pellagra. Okay? So, again, episodic skin flushing, diarrhea, and wheezing are the most common things, but these are also complications you can get: right-sided heart failure and pellagra. There's a rule of thirds that you want to know. 1/3 metastasize, 1/3 are multiple tumors, 1/3 present in conjunction with a second malignancy. Now, the way we diagnose a carcinoid tumor is you check for 5-HIAA levels in the urine. And that's because 5-HIAA is a metabolite of serotonin. Serotonin is metabolized into this in the liver and the lung by monoamine oxidase. Okay, so you check for 5-HIAA in the urine. If it's increased, you know it's a carcinoid tumor. And that's it. So next is the VIP-oma. We talked about this in the GI system already. But this is a tumor with oversecretion of vasoactive intestinal peptide. So what does vasoactive intestinal peptide do? First of all, you know it acts in the intestine, vasoactive. So it increases intestinal water and electrolyte secretion into the gut lumen. So that's going to cause increased motility, and you have oversecretion. This is what I just said. If you have oversecretion, you're going to get overactive motility, you get watery diarrhea. And this tumor most commonly arises in the pancreas. So watery diarrhea is the main symptom, and this is again associated with WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria. Where achlorhydria stands for, it means basically absence of HCl and gastric secretions. Why is that? Because you're losing all that electrolyte in your gut. So now you don't have enough Cl, so you don't have HCl in your gastric secretions. You have achlorhydria. Okay, finally treatment. Treatment for all this stuff, first of all, neuroendocrine tumors include all this stuff. Insulinoma, everything we just talked about. Insulinoma, glucagonoma, somatostatinoma, carcinoid tumor, VIP-oma, and also pheochromocytoma, which we haven't talked about. So these neuroendocrine tumor basically means it's a tumor of cells. It's cells that receive nerve input and they release hormones. So hence the neuroendocrine name. Okay. I also want to note that stuff like small cell carcinoma of the lungs, medullary carcinoma of the thyroid are also neuroendocrine tumors. These are tumors that release hormones. Where small cell carcinoma of the lungs releases ADH, releases ACTH. What is medullary carcinoma of the thyroid release? It releases calcitonin. Now, treatment for all of these are similar, which is why I've just lumped it into one little box here for all these tumors. Treatment is basically one, you take out the tumor, which is obvious, surgical resection of the tumor, and then you can also try octreotide. This is a somatostatin analog. You hear this a lot, and it helps with symptom control. Why is that? Because it acts like somatostatin. It reduces hormone secretion, and in a neuroendocrine tumor, your symptoms are from that oversecretion of hormones. Okay, I want to point out one last thing is that this general treatment is going to be the same for all these neuroendocrine tumors except for pheochromocytoma. So I'm going to cross that one out. We're going to get into pheochromocytoma in a second. Okay, but for all these other tumors, you cut out the tumor, and you can also try giving them octreotide for symptoms. Alright, so that's it for our part 1 of neuroendocrine tumors. We're actually going to talk about pheochromocytoma and neuroblastoma. These are both tumors of the adrenal medulla. Actually, screw it. Let's just talk about it now. So tumors of the adrenal medulla. We talked about tumors of the pancreas. We talked about a couple other tumors, such as the carcinoid tumor, VIPoma. So now we're going to go into the adrenal medulla. So now we have a neuroblastoma. This is the most common tumor of adrenal medulla in children. We talked about this in the renal lectures, actually. And these originate from neurocrest cells. They can occur anywhere along the sympathetic chain, but most commonly they occur in the adrenal medulla. So the sympathetic chain, let's blow this up here. Remember, this is the sympathetic chain right here. It's outside of the spinal cord. You have all your sympathetic nerves go along this chain, and eventually they go to the target organ. So you can get a tumor anywhere along that chain. Now this tumor is associated with the N-MYC oncogene overexpression. And do you remember, if you watched the renal lecture, do you remember the characteristic physical exam finding of a neuroblastoma? And how do you differentiate it from Wilms tumor? This is a large irregular abdominal mass that can cross the midline. In comparison, what is a Wilms tumor? Wilms tumor is smooth and does not cross the midline. So if it crosses the midline, it's a neuroblastoma. If it's you see in a kid, you have a kid with the abdominal mass, then you have to check if it crosses the midline or not. If it crosses the midline, it's a neuroblastoma. If it doesn't cross, it's Wilms tumor. What you're going to see is you're going to see increased HVA and VMA. Why is that? Well, first of all, what hormone is going to be released in a tumor of the adrenal medulla? First of all, what does the adrenal medulla even release? Remember, it releases catecholamines like norepinephrine, epinephrine. These are going to get broken down, and these are the metabolites, HVA and VMA. So you're going to see increased urinary HVA, urinary VMA. On histology, you're going to see Homer-right rosettes. Just another quick throwback. You see these also medulloblastoma of the brain. Okay, so that's neuroblastoma. That's the adrenal medullary tumor in kids. Now, if you have adrenal medullary tumor in adults, it's most likely a pheochromocytoma. Let's erase this so you can see. And this develops from chromaffin cells, also of neurocrest origin of the adrenal gland. And again, you get oversecretion of catecholamines, epinephrine, norepinephrine, dopamine. These all cause symptoms. Now, you can be associated with some inherited mutations, which unfortunately you need to memorize. VHL, von Hippel-Lindau syndrome. You get Rett. Remember, Rett is associated with the MEN syndromes. We're going to talk about that in a second. And then NF1, neurofibromatosis genes. This is lower yield. So this is actually lower yield, and I just want you to know that. Now, symptoms here, there's also a very characteristic and classic presentation. You have too much catecholamine release. What happens? What happens to your heart and your heartbeat, your pulse, your blood pressure? Well, okay, first of all, you get your heart beats faster, you get tachycardia, you get hypertension. Hypertension will lead to headache. So hypertension and headache, tachycardia, you get sympathetic stimulation, so you get sweating. And the thing is that these symptoms come in episodes that relapse and remit. This because you have fluctuations in your catecholamine release and synthesis. So you're going to get episodic hypertension, tachycardia, sweats. It's going to come and it's going to go. That's pheochromocytoma. It's easy peasy. Actually, there's stuff that can mimic it, but on the test, it's pheochromocytoma. And you get a rule of tens. You have 10% malignant, 10% bilateral, 10% outside of the adrenal gland, outside of the adrenal medulla. Okay. How do we diagnose this? We look for serum and urine catecholamine, so epinephrine, dopamine, norepinephrine, and you look for metanephrines. These are metabolites. Okay. And how do we treat this? Well, similar to we said neuroendocrine tumors in general, you want to resect it. But in this one, you don't want to go straight and resect it. What's going to happen? If you go straight and resect it and you go push on that adrenal medulla, you're going to be pushing out all these catecholamines. You're going to have problems. So what do you have to do first? You first have to give irreversible alpha blockers Then you follow with beta blockers. First you block alpha, then you block beta. And why am I picking, being so picky? Why do I have to be? Why does it have to be A before B? Well, let's do a little thought experiment. What happens if you block beta? If you do beta blockers, you have beta blockade, and then remember beta blockade. The beta is for like heart output, the heart contraction. What happens if all of a sudden your adrenal medulla releases all these catecholamines? You get these catecholamines are going to stimulate the alpha receptors, which are not blocked because you did the wrong thing, and then however your heart doesn't get that beta stimulation because you blocked it. So now you have super vasoconstriction, you get severe hypertension, you're going to have problems. Okay, so that's why you have to block the alpha first to prevent that. You block the alpha, then you block the beta, then you go do surgery, and then you're going to manipulate the tumor, and it's going to release the catecholamines, but it's going to be fine because you have these blockade of alpha and beta receptors. And that is how you treat pheochromocytoma. So, again, neuroblastoma in kids, pheochromocytoma in adults, both of them release too much catecholamines. To diagnose, you see that urinary HVA and VMA in kids, and for pheochromocytoma, it's just serum and urine catecholamine and metanephrines. You do want to know this rule of tens. Pheochromocytoma has that really characteristic presentation with episodic catecholamine surges. For neuroblastoma, you have that physical exam finding. It's very characteristic. It crosses the midline. It's irregular abdominal mass. So that's it for tumors of the adrenal medulla. And finally, we go into the multiple endocrine neoplasias. These are syndromes with multiple tumors. So you have MEN1 and MEN2. So MEN1 has 3 tumors. Parathyroid tumor, and what would you get? What electrolyte abnormality would you see? Parathyroid hormone, remember, increases calcium, so you get hypercalcemia. You have a pituitary tumor, especially a prolactin. And what was that physical, a visual finding you would see in a pituitary tumor? You see that bitemporal hemianopsia, remember that? And then finally you have pancreatic tumors, especially a gastrinoma. Gastrinoma release too much gastrin, causes too much release of HCl in the stomach, it causes ulcers. So that's MEN syndrome, parathyroid, pituitary, pancreatic tumors. Now we have MEN2 syndrome. So MEN1 syndrome is from a MEN1 mutation gene. MEN2 is from a RET mutation gene. And we can subdivide MEN2 into MEN2A and MEN2B. So both of these MEN2 syndromes are characterized by pheochromocytoma and medullary thyroid carcinoma. So pheochromocytoma, what I just tell you was that very characteristic symptoms. Episodic, remember the key word is episodic, hypertension, headaches, palpitation, sweating. And the medullary thyroid carcinoma, what hormone do we say was released from this? Remember, it's calcitonin. And finally, MEN2A is going to have parathyroid hyperplasia. MEN2B has a mucosal neuroma. So mucosal, like oral or intestinal, both of those have mucosa. And you have a marfanoid habitus. What was a marfanoid habitus? What does that mean? When it's like the longer arms, they have joint laxity. So MEN2A has pheochromocytoma, medullary thyroid carcinoma, parathyroid hyperplasia. MEN2B also has pheochromocytoma and medullary thyroid carcinoma, and also has this stuff, mucosal neuroma, marfanoid habitus. Just to make it easier to remember, okay, all of these have autosomal dominant inheritance, so just remember dominant men. And then MEN1, as you can see, has 3 P's. MEN2A has 2 P's. What were the 2 P's? We see pheochromocytoma, parathyroid hyperplasia. MEN2B has 1 P, just the pheochromocytoma.